Okay, so in this video, we will be talking about the spinal cord and its ascending and descending tracts, and finally the intersegmental tract. So to begin with, we have our gray matter. So all of you, basically gray matter is the accumulation of your neuron cell bodies, and white matter is the axons, the myelinated axons forming the whitish appearance. So let's begin with our gray matter. The gray matter in the spinal cord here looks like a H, horn-shaped structure. And this horn-shaped structure has three horns. The first one is your anterior horn, lateral horn, and then your posterior horn. Or you can call them as anterior gray column, AGC, or lateral gray column, LGC, and posterior gray column, your PGC. Now, in these gray columns, there are certain nucleuses present. What are nucleus? Nucleus is nothing but an accumulation of your neuron cell body. Now, let's see what type of nucleus is present in every single gray column of your spinal cord, starting with the posterior gray column. In the posterior gray column, you have three nucleus present. In the posterior most aspect, you have a nucleus called as a substantia gelatinosa. Anterior to that, you have something called a nucleus proprius. More anterior to that, you have something called as nucleus dorsalis, which is also known as your Clark's column. Now, what are the functions of the neuron cell bodies present in each of the nucleuses? Let's start from the beginning. Substantia gelatinosa. It is present throughout the length of your spinal cord, and it has your Golgi type 2 neurons. And substantia gelatinosa has neuron cell bodies which helps in the function of detecting pain, temperature, and your touch. Now, what about nucleus proprius? It is the main bulk of neurons in the posterior gray columns. That means nucleus proprius accompanies most of the space in the posterior gray column. And what does it do? It helps us in proprioception, 2-point discrimination, and vibrational senses. So that was about nucleus proprius. What about nucleus dorsalis, which is also called as a Clark's column? It is present only from the level of cervical segment 8 to the level of lumbar 3 or lumbar 4. And the function of nucleus dorsalis is to detect neuromuscular and tendon spindle sensory functions. So basically your postures, your movements, and all those things, joints, tendons, all of those spindle movements are detected by your nucleus dorsalis, and the cell bodies of it is accumulated in this part. So you may call this the base of your posterior gray column. So in the exam, if they're going to ask you a question, what nucleus is located in the base of the posterior gray column, that answer should be nucleus dorsalis. And what is the nucleus located in the apex? That should be your nucleus substantia gelatinosa. Fine. That was about your posterior gray column. Now, what about anterior gray column? Anterior gray column has three major groups of cells. But here I mentioned only two of them because the central group is very small and it is not visible easily. So medial group. Medial group has nucleus that helps in motor function of your skeletal muscles, especially your neck, trunk, intercostal muscles, and your abdomen. This is the highest amount of nucleus present in the anterior group column. That means it is abundant. Now, what about lateral group column? It is present laterally. It has nucleus which provides motor information to your upper limb and your lower limb. To be more specific, upper limb in the cervical segments and lower limb in the lumbar and sacral segments. So basically, the lateral group present in the cervical segments help in the motor function of your upper limb. The lateral group present in your lumbar and sacral sections helps in the motor movement of your lower limb. Fine. So remember, always posterior is sensory, anterior is motor. Now, what about lateral? Lateral has preganglionic sympathetic outflow. Remember, in anatomy, we would have studied preganglionic sympathetic chains across the vertebral columns. So those are part of your sympathetic system. So the nucleus of these systems are going to be relayed at your lateral gray column at this red spot right over here. So preganglionic sympathetic outflow is seen in your lateral gray column. Now, another fact here to remember is at the sacral levels. At the sacral levels, your lateral gray column has preganglionic parasympathetic outflow. So this is a fact to remember. So this covers our spinal cord. Apart from this, I told you about the central group, right? Here are some facts about the central group. It is the smallest group of nucleus present in your anterior gray column. And what does it do? Central group nucleus from C3 to C5 forms your phrenic nucleus, which supplies your diaphragm muscle. Now, what C1 to C5 or C6 forms your accessory nucleus, which supplies your sternocleidomastoid and your trapezius muscle. L2 to S1 forms your lumbosacral nucleus. So these are some facts about central group that you must remember. So again, as a revision, in posterior gray column, you have three main nucleus. In lateral gray column, you have one. And in anterior gray column, you have three, which is your medial, lateral, and your central. Medial is the highest amount present. Central is the smallest amount present. Now, in the anterior gray column, remember, anterior gray column is motor. So there are two types of motor nerve fibers. One is alpha, the other is gamma. Alpha fibers are large and they supply your skeletal muscles directly. Gamma fibers are small and they supply your intrafusal and neuromuscular spindles, which helps in proprioception. So alpha and gamma, large, small, and remember what they supply. These belong to your motor neurons present in your anterior gray column. So that was about your gray matter. Now let's look at white matter. This page might look a little bit overwhelming, but I will decode this for you so that you can use it as a reference for a quick revision. So let's start. White matter is divided into three tracts, starting from your ascending tract, descending tract, and your intersegmental tract. Ascending tracts are the sensory tracts to your brain from your spinal cord. Descending tracts are your motor tracts from your brain to the spinal cord. So these are motor. Ascending is sensory. Now, ascending is divided into three major tracts. One is your posterior column, one is spinothalamic, and the other is spinocerebellar. Posterior column and spinothalamic has three neurons. So that means it will have first order neuron, second order neuron, and third order neuron. Whereas spinocerebellar will have only two neurons. So first order and second order neurons only. Now, under posterior column, there are two more fasciculus. Fasciculus means bundle of nerve fibers. One is fasciculus gracilis, the other is fasciculus cuneatus. Fasciculus gracilis will take sensory impulses below the level of T6. So this down arrow means below the level of T6. Fasciculus cuneatus will take sensory impulses from above the level of T6. What kind of sensory information? Proprioception and discriminative touch. That is what is going to be carried by your posterior column to your brain. And how is it going to carry? In which direction? It is ipsilateral in direction. And the fact here to remember, a crucial fact here to remember is it is going to be travel in an ipsilateral direction, but at the end, it is going to cross. The second order neuron is going to cross in the medulla oblongata at your medial lemniscus and ends at the other side of the cerebrum. So it basically travels in one single ipsilateral direction, but at the end, it is going to cross to the other side. So that was about your posterior column, your fasciculus gracilis and fasciculus cuneatus. It is highly important to remember fasciculus gracilis supplies below the level of T6, fasciculus cuneatus supplies above the level of T6. Now, what about spinothalamic tracts? Spinothalamic tracts are divided into two types, your lateral spinothalamic tract and your medial spinothalamic tract. And remember, there are three neurons for this, primary, secondary, or you can say first order, second order, and a third order neurons. Now, lateral tract is going to carry your pain and temperature sensations. Medial tract is going to carry your non-discriminative touch and your pressure sensations. How are they going to carry? In which direction? Contralateral. And when are they going to cross? They are going to cross as soon as they enter the spinal cord. But whereas here you saw they crossed in the medulla. So let me write medulla. But whereas here they cross as soon as they enter the spinal cord at the level of the segment through which they are entering. So basically that is the reason why spinothalamic tract travels in contralateral direction. Now, finally, spinocerebellar tract. It has only two neurons, your first order neurons and your second order neurons. It is divided into posterior and anterior divisions. What is spinocerebellar? It is going to take sensations from your spinal cord to the cerebellum regarding the posture, the balance, the movement, and everything. Cerebellum means always related to movement, posture, locomotion, and all those words. So from spinal cord to your cerebellar. Now this is divided into posterior and your anterior division. Posterior has your inferior cerebellar peduncle and your anterior goes through your superior cerebellar peduncle. From the inferior cerebellar peduncle, it is going to reach your cerebellar cortex. And at the same time, from the anterior spinocerebellar tract, it is going to reach the cerebellar cortex to your superior cerebellar peduncle. Now, let me recap it once more. Spinocerebellar tract is divided into posterior and anterior tracts. Posterior is going to enter your cerebellum through inferior cerebellar peduncle. Anterior is going to enter your cerebellar cortex through superior cerebellar peduncle. How are they going to travel? This posterior one is going to travel ipsilaterally. This anterior one is also going to travel ipsilaterally, but it is going to cross twice. It is going to start at one point, cross in the spinal cord, go up and cross again in the midbrain. So basically, it crosses at spinal cord and your midbrain at the same time. So that is your two crosses. This is the only tract that we are discussing in this whole video that will cross twice, your anterior spinocerebellar tract. And remember, it is related to your movement, posture, and your locomotion. And it carries sensations from your spinal cord, hence spinocerebellar. Now, there are other minor tracts that are really important. Spino-olivary tract, spinotectal tract, and a spino-reticular tract. Spino-olivary tract is going to take sensations from your spinal cord to your inferior olivatory nucleus. And it's going to take it directly to that place. There is no cross. Spinotectal tract has two neurons and it is going to cross. And where does it take? It takes from spinal cord to superior colliculus of your midbrain. So just don't get confused with this SC. This SC means superior colliculus. So it is going to take from your spinal cord to your superior colliculus of your midbrain. For what? For visual reflexes. So tectal means you can say it is related to visual and the superior colliculus handles your visual reflex. So spinotectal is going to cross at one point. It has two neurons and it carries sensations from your spinal cord to your superior colliculus. Now, what about spinoreticular? It is contralateral and it is going to carry pain and temperature impulses from your trunk and limbs to your reticular nuclei. Fine. Now, these three are the other tracks that you have to remember under your ascending tracks, which are sensory. So whatever we saw now is just to make us realize that this is happening, sensation. Now, the next type of tract, white matter tract we are going to see is motor, the one which is going to create action. Motor is divided into two types, direct and indirect. Direct is voluntary and indirect is involuntary. So that means we can easily say that direct is conscious, indirect is subconscious. Direct is going to happen through few nerve fibers called your pyramidal tract. Indirect is going to happen through your extrapyramidal tracts. So under direct, you have two major tracts called corticospinal and corticobulbar. Corticospinal is further divided into lateral and anterior part. This lateral part is going to control your distal muscles of your upper limb and your lower limb. By distal muscles, I mean your digits. So it is going to control your digits, the lateral corticospinothalamic tract, which is 85%. Whereas your anterior corticospinal tract is going to control your proximal apertures like your arms, your shoulder joint, and everything. So this is 85%, this is 15%. And this is going to travel contralaterally. Now, what about indirect? Indirect, remember, I told it's subconscious. Okay, before that, let me talk about corticobulbar, which is also part of direct. Bulbar means your brain stem. So in your brain stem, you have very important cranial nerve startings. So cranial nerves such as 3, 4, 6, 7, 9, 11, 12 are originating from your brain stem. And these cranial nerves help in the movement of your eye, jaw, face, neck, pharynx, and all those things. To coordinate that movement, to give motor sensation for those muscles in our head and neck, these corticobulbar tracts are important. So these are all voluntary and it happens consciously. Whereas indirect one is subconscious and you have four major tracts for it. I've explained them down below. First is your rubrospinal. Let me write it down. Rubrospinal. Rubro means it starts from your red nucleus. All right. So rubrospinal starts from your red nucleus and it controls your tone of flexor muscles. Flexor muscles, in the example, you can take your biceps. Triceps is the extensor of your biceps. So basically, rubrospinal tracts are going to control your tone of flexor muscles. It's just going to control the tone, not the entire flexion itself. So that is why it is subconscious. What about TS? TS is tectospinal. It is going to control your movements based on the visual input you receive. Imagine this is an eye. You are going to receive some input. And according to that, you're moving your head and neck. And that is done by your tectospinal. Now, vestibulospinal. What is vestibulospinal? It is related to your balance and posture. Vestibulospinal has two tracts, lateral and medial tracts. Lateral tract is going to travel ipsilaterally, but medial tract is going to travel bilaterally, both the sides. So in these tracts, we saw one tract which is crossing twice, right? We saw this spinocerebellar anterior tract crossing twice. But this tract is another different type in which it goes down twice, bilaterally. It is not crossing twice, but it's traveling in two paths. That is your medial vestibulospinal tract. Now, lateral vestibulospinal tract is from your lateral vestibular nuclei. This is also known as your Dater's nuclei. Okay. And your medial nuclei is for your medial vestibulospinal tract. Now, you have your reticulospinal tract. Reticulospinal tract is involved with your breathing, controls your breathing movements, and that is ipsilateral. And again, remember, this is your involuntary breathing. It happens subconsciously. And there is finally DA. What is DA? DA is your descending autonomic fibers. Autonomic, you obviously know it is sympathetic and parasympathetic. So these fibers are going to follow your reticulospinal tract as they descend down and control your sympathetic and parasympathetic outflow. So in this entire page, we have just covered the entire white matter, ascending tract, descending tract. The only small portion that is left is your intersegmental, which is also known as the propriospinal. Intersegment tract is very simple and we've been studying it since our schooling days. So it just involves a reflex arc starting from your receptor. You touch someone, receptor takes the sensation through your sensory neuron to your spinal cord. In the spinal cord, it is going to integrate the information and through motor, it is going to come back and is going to cause the reflex to your effector neurons. So this is our reflex arc. So when there is only one thing involved, one reflex arc, it is called as monosynaptic reflex arc. So that is intersegmental. So basically in this one page, you can just revise the entire white matter very easily, but make sure you just understood what I said so that you can understand these small terms like here. TS means tectospinal, VS means vestibulospinal, RES means reticulospinal, RS means rubrospinal. DA is descending autonomic fibers. Okay, now here's another interesting thing that we must know. There is posterior white column and anterolateral white column in the spinal cord. In the posterior white column, U means upper for reference, L means lower. In the upper segments, the nerve fibers enter laterally. What do I mean? In the posterior white column, your cervical segments enter the spinal cord laterally. But in the lower segments, like your lumbar and sacral segments, enter your spinal cord medially. This is in your posterior white column. But when you take your anterolateral column, in that upper segments, your cervical and upper thoracic segments, enter your spinal cord medially, whereas your lower segments, sacral and lumbar, enter your spinal cord laterally. It is the complete opposite. So just remember posterior right column, anterior column. Just remember one so that you can put the opposite for the other one. Okay, now this is a really beautiful table summarizing whatever I just said. The sensations, where is the first order neuron located, where is the second order neuron located, where is the third order neuron located, where does it finally end, and the crossover site. Now, If you remember, we studied that fasciculus gracilis and fasciculus cuneatus is ipsilateral, but at the end, it is going to cross over and go to the opposite side of your cerebral cortex. So see the final destination, primary sensory cortex on the opposite side. So be careful about this. And other than that, you can see posterior spinocerebellar tract never crossed and anterior spinocerebellar tract crossed twice in the spinal cord and in your midbrain. And most of the first order neurons are located in your dorsal root ganglion. And most of the third order neurons are located in your posterolateral ventral nucleus of thalamus, because thalamus is your relay center. And the second order neurons are listed down here below. So you can just remember it according to the gray matter nucleus I just taught. So substantia gelatinosa, nucleus proprius, everything is mentioned here. Just go through it and remember the second order neurons for every tract. Okay, now to the final part of this video is the clinical notes. Starting from a clinical note called as your tabes dorsalis. It is caused by syphilis infection. So when this syphilis is severe, what it's going to do is the virus is going to destroy your posterior root of your spinal cord. So once that posterior root is destroyed, you are going to have the following symptoms: stabbing pain in your lower limb, paresthesia, that means numbness in your lower limb, hypersensitivity, sometimes loss of sensation. There is less awareness if your urinary bladder gets filled. So the person might urinate anytime. Decrease in postural awareness, hypotonia, and decrease in tendon reflexes. So under tabes dorsalis, remember it is caused by syphilis and it is the destruction of your posterior root. And these are the symptoms. Now, another important thing we must remember is in the motor tracts, which is your descending tracts, there is a tract called corticospinal, which is really important. If this tract is going to be destroyed, then that leads to a sign called Babinski sign. What is Babinski sign? Usually, the normal reflex when you touch a foot. So imagine this is a foot, not specifically. So when you touch the sole of the foot is going to flex plantar flexion. So normal is plantar flexion. Normal is plantar flexion. But when the corticospinal tract is destroyed, there is going to be dorsiflexion of toes. So that means it's going to come up. It's going to come up and the toes are going to spread apart. So when this happens, it is called positive Babinski sign. But remember, in babies which are less than 1 year old, these babies have their corticospinal tract less myelinated. So there's a high chance that babies can also exhibit dorsiflexion, which is your Babinski sign, which will be completely normal because myelination will happen over the course. After 1 year, the corticospinal tract is going to get myelinated. But until then, babies also can demonstrate Babinski sign. But if a patient presents with corticospinal tract destruction, the major feature you can notice is your positive Babinski sign, which is your dorsiflexion of toes. Normal one is your plantar flexion. Now, what about paralysis? Let's learn some common words which are confusing. Hemiplegia, one-sided paralysis. Your arm, your trunk, and your limb in one side is going to get paralyzed. Monoplegia. Monoplegia is the paralysis of one limb. For example, your one arm or your one leg, one left leg or one right leg, anything. Diplegia is the paralysis of both of your arms or both of your legs separately. Paraplegia is the paralysis of both of your lower limbs. Finally, quadriplegia is the paralysis of all four limbs. So these are the 5 different types of paralysis that you should remember. Okay, now here are some other terms that you must know. Athetosis, chorea, dystonia, myoclonus, hemibalismus. These are really new words, but these are very simple. Athetosis are slow, involuntary, and rapid movements. I'm sorry, not rapid movements. They are slow and involuntary movements that disappear during sleep. These happen again and again in a patient. Whereas chorea is continuous, rapid, jerky movements. But this does not disappear in your sleep. So athetosis disappears in your sleep. chorea does not disappear in your sleep. And athetosis is slow, chorea is fast, jerky movements. Both of these are caused due to your lesion in corpus striatum. Fine. Now, dystonia. Dystonia is the contraction of hypertonic muscles. If a muscle is already hypertonic in nature, and if that muscle is going to get contracted, that is called a dystonia. And that happens when there is a lesion in your lentiform nucleus. Okay. Myoclonus. What is myoclonus? Myoclonus is the contraction of one isolated muscle. And that happens when there is a lesion in your reticular formation. And finally, hemibalismus. It is the flying of all your proximal limbs in different direction, like ballistic, like missiles. That is due to the subthalamic nucleus lesion. So remember what are these, and remember what nucleus lesion causes what. So these are some new terms, and I did not include terms like spasms, hypertonic, hypotonic, because those are really basic terms that we must know by now. Okay, now finally, what are the spinal cord syndromes? This is complete cord transection. Just by looking at the image, it is obvious. And this can lead to all kind of losses, like contralateral, ipsilateral, all kind of losses. Anterior cord syndrome. This is your central cord. Only the central portion is getting affected. Brown-Sequard syndrome. Only one half of the spinal cord is getting affected. Syringomyelia, it is a inherited syndrome. It is born, it is congenital. I'm sorry, it's not inherited, it's congenital. And it affects mainly your gray commissure and the nearby portion along it. And poliomyelitis, it is going to affect your anterior gray column, which is going to affect your motor tracts. As a result, your muscles are not going to be used. And if you would have seen a polio patient, their muscles would have been hypertrophied, they would have been small, contracted, wrinkled, or such. And finally, you have amyotrophic lateral sclerosis, which also affects your anterior gray column and some of the fibers from your anterior lateral gray column. Now, I did not include all of the symptoms for all of these syndromes because the symptoms keep going on and on and on. So I recommend you to take your Snell's neuroanatomy and look at the symptoms for each of the symptoms, each of the conditions here, so that you can be more clear about it. So that was about the spinal cord ascending and descending tract, including the clinical notes. Now I will be attaching the PDF in the description of this video. You can definitely use this for revision, but also make sure you go through your Snell's neuroanatomy book at the end. Thank you.